Corla. Minister, thank you. I'm happy to be here just to contribute to this debate this evening on health insurance. And I note from the preamble in the Oireachtas, essentially we're talking about reducing the amount of money paid to insurers by way of risk equalisation based on the credits of age, gender, level of cover, also known as age-related health credits. We're introducing a new system of high-cost claim credits and reducing stamp duty payable on all health insurance policies that feeds into the Central Support Fund. So I presume that these have been largely costed and are deemed to be beneficial, Minister. Otherwise, I doubt you'd be proposing them. And you've said here tonight that the scheme is revenue neutral and any surpluses or deficits that occur are rolled over into following years. You've also taken note of the high level of take-up of insurance, which now stands at over 2.3 million people in the country now have health insurance policies, and that's to be applauded, I would say. But I would also point out to you, Minister, there's a large discrepancy between different policies as well, you know. And as people age in the present way we do health, you tend to gear up your policies as you become older, because essentially risk equalisation or not, the chances are that some of the policies at the lower end may not cover you for some of the serious health obstacles that you may face as you age. And so I think it was referred to here already this evening, you have pensioners there, a couple of pensioners paying anywhere between €3,500 and maybe even up to €5,000 for the likes of a high-level scheme of insurance. And that seems very difficult on people who've paid tax all their lives generally, and maybe what you're proposing tonight. And as this bill progresses, this will deal with some of those, I would call them, inequities really. But can I just speak about a couple of things that's come up here a number of times in the debate tonight, is the issue of private and public hospitals and private and public activity work. And it's very hard to compare what happens in the public hospital sector with the private hospital sector, because they generally relate to different streams of activity. If you're in the private sector, you're looking for kind of fast, straightforward, repeatable exercises that you can turn around, that you basically create fee income, and that's what private hospital care is largely based on, private fee income. The public system is the social contract that we have, where we decide that we look after everybody, regardless of their health needs. But that also includes people who have very, very chronic health needs across a range of medical areas. They require lots of care. They require ongoing treatments, both in hospital and in community, and that's picked up largely by the public purse. And so when we talk about sláinte care, we're talking about, in effect, trying to get the efficiencies of the private system while having the public good at the heart within sláinte care policy. And it's going to be a very difficult circle to square, to be quite frank with you, because there's a lot of work to be done in trying to generate that. And I know other deputies have spoke here tonight about the need to implement sláinte care. But I would point out to you there's significant obstacles at the moment in the recruitment of qualified healthcare medical people. We are at present enjoined and talking about a new consultant hospitals contract, and if you go and speak to new doctors qualifying, they will tell you, a lot of them, that they're not going to work in the public system for the contract that's available being offered to them. They're going to emigrate. So we'll have spent the money educating them. We don't have any system in this country or bursary to provide medical related teaching that would contract them to work in the system for 1, 2 or 5 years like other countries. So we'll just educate them and then we'll let them fly. And at the other end of the scale, you have people who have worked as hospital consultants for 20, 30 years, and they may still have time in their contracts to run, but they're not going to stay in the system much longer because, quite frankly, they've had enough with a lot of it. So we have lots of reform to deliver within that. I'd also speak to you about waiting lists, tests and scans, and Deputy Naughton has highlighted there tonight how level 2 hospitals can do a lot of this work, and I agree with that. And certainly they should be funded by the private health insurers, and that's an easy initiative to put in place, Minister, if the will is there. There's also a couple of schemes around the insurance-backed long-term care, and I'd point out the VHI Hospital at Home, which is a system now where if you're a VHI patient and if your needs are chronic, not acute, you may be able to get minded in your home. So essentially the VHI will pay for people to come and deal with you at home, and that's a very efficient system at releasing beds in our public hospitals as well as in the private hospitals. something along those lines as the OPAT therapy, the outpatient antimicrobial therapy. And at the moment, Minister, we have patients coming into hospital taking up a bed for a half a day or a day to receive antimicrobial therapy. That can be done quite easily in the home if we have the nurses or qualified doctors to do it. And again, that's something that I know there's a pilot being discussed at the moment, but we don't need to pilot that. This is simple stuff. We just decide we're going to do it and we see what resources that we have to do it. In terms of Deputy Naughton's case and his amendment, I will be supporting that amendment, Minister. I think it is a discrimination of a Model 2 hospital that any health insurer would not be paying for procedures that they pay for in other hospitals. They're the same procedures, and I agree with them that they should be not remunerated under the fund until that case has been levied. But as I say, Minister, the idea of Sláinte care, I would ask the question, is it realistic in the guise that we are talking about it now? And one of the things, and I've been around healthcare for a long number of years, one of the things that I notice about a lot of policy discussions, they generally don't include those who actually have to deliver the service. We talk about what we're going to do in terms of efficiency, but we don't speak to the nurses. We talk about what we're going to do in terms of high-level clinical management. We don't speak to the CNMs, and we rarely involve the consultants, to be quite frank with you. And I don't take the view, as other deputies might, that somehow the consultants are an outlying class in medicine and that they're all out for money. I know very many consultants who are quite the opposite. They are very much pastoral people, and their first inclination is to serve and to mind and to look after their patients. And we have created the consultants' contract that they work under, and many of them are quite happy to work under the system. But what they do want is support, Minister, and they want the proper resources, and they want adequate resourcing at the junior levels that they need. If they need registrars, if they need house officers, if they need junior doctors, if they need CNMs, if they need secretaries, they need all of that. And why they're getting basically tanked off is because when they go into the system, they don't have that. And that's why you're seeing so many people saying that the system is dysfunctional. The system is difficult, and when you offer public health care to all, it is going to remain difficult. We have to learn the efficiencies that are in the private sector, and we have to see how we can bring them across into the public sector while getting a risk and getting a payment equalisation for all. Good.